subcutaneous fat is incised using electrocautery. The fascia of the external oblique muscle is incised diagonally. The combined fascia of the internal oblique and transverse muscles is incised in a more vertical fashion. The preperitoneal space is exposed, and the inferior epigastric vessels, as well as the rotund ligament in females or spermatic cord in males, are identified and secured with a vessel loop. The lowest part of the posterior rectus sheath is incised. After this, the retroperitoneal space is reached by gently pushing away the peritoneum. Its contents are held by a retractor. The common external and internal iliac artery and vein are identified and dissected from fatty tissue and lymphatic tissue to make clamping of the vessels possible. The iliac arteries are investigated by palpation for atherosclerosis. The kidney is now retrieved from cold storage. In this animation, it has already been prepared for transplantation and pre-transplant biopsy has been taken. Corner stitches are applied to the renal vein edges. The kidney is placed into the iliac fossa in the best possible position, and the length of the renal vein and artery may need adjustment. First, the vein-to-vein anastomosis is done. If needed, the iliac artery is retracted very gently to improve access. The iliac vein is clamped and cut. And the incision is extended. A supporting pull-out stitch is placed on the medial side to keep the lumen open. A heparin solution is used to rinse and clean the lumen from blood and small thrombotic material. The renal vein corner stitches are connected to the corners of the opening of the iliac vein, and from one corner the venous anastomosis is performed, in general by using a 5/0 unabsorbable monofilament running suture. The supporting stitch is removed and both remaining sutures are knotted. Next, the iliac arteries are clamped. The artery, preferably the common iliac, is incised and the opening is enlarged using a 4 mm aortic punch. The artery is cleaned with heparin solution. The arterial anastomosis is now performed using a parachuted 6/0 unabsorbable running suture. Before reperfusion of the kidney, the renal artery is clamped close to the anastomosis. This is done to prevent blood clots to go into the kidney. First, the arterial clamps are removed and the anastomosis is checked. If there is no major bleeding,